Tennessee Medical Center at Knoxville experience. So I will be the first speaker, and then 5 of my colleagues, including 3 of our residents, will be presenting the talks which you guys all have the schedule for. So today I will start the talk with the prognostic value of estrogen receptor, progesterone receptor, and HER2 for breast cancer biomarkers and AJCC TNM staging system on overall survival of Caucasian females with breast cancer. And I will tell you our institution's 10-year experience. As you are all aware, the American Joint Commission on Cancer had 50th birthday in 2009. And they are having the TNM staging as the overall global staging of all cancers. And this 50th birthday was followed by issuing of the 7th edition of Cancer Staging Manual, which actually still related the breast cancer staging only based on anatomic classifications as tumor size, like T, N, nodal stage, and M, metastasis stage. Although the Breast Cancer Task Force, as well as many recent proposed biological TNM staging systems to improve the TNM accuracy for staging, prognosis, and treatment were proposed. The American Joint Commission on Cancer resisted urge to include biomarkers as a biological TNM, having in mind that we will see the recent developments, and then maybe the next issue will actually incorporate biological markers into the classic traditional TNM system. In the meantime, we were trying to see in our own institution what the biological markers mean in overall survival in Caucasian patients, simply because our institution is based in Knoxville, Tennessee, where more than 95% of population is Caucasian, so we were actually limited to do our studies on Caucasian patients. Our initial study, published in Breast Journal in 2013, was on 595 Caucasian patients with invasive breast cancer. The study period was only from 2000 to 2004. What we actually showed is that traditional TNM status and age were significant predictors of overall survival. But estrogen receptor, progesterone receptor, and HER2 expressions were not predictive when using one of the proposed classification system, which is St. Gallen 5-group ER/PR/HER2 subtype classification. And I will touch upon how they are dividing it a little bit later in the talk. The present talk is going to be focused on our recently published study in Breast Journal again in 2015 in March, when we were asking the question, what is the relevance of tumor biomarkers in the recently proposed biological TNM classification system proposed by Bagaria et al., published in JAMA Surgery in December of 2014, in which inclusion of triple negative ER/PR/HER2 phenotype could improve the prognostic accuracy of TNM. And then I will briefly touch upon one of our ongoing studies, which would include classification system that uses only ER biomarker status, but also incorporates grade into the TNM stage, and see whether or not that can improve prognostic accuracy of TNM. So for that recently published study with from 791 Caucasian women diagnosed with primary invasive ductal carcinoma, and pay attention, this is not all invasive breast cancers, but only ductal carcinoma, trying to mimic really to the dot Bagaria study. We had it in a 10-year period. 782 patients ended up having complete data. patients were categorized according to their TNM stage and triple negative versus non-triple negative phenotype, and then we were looking at their overall survival, measuring, comparing these categories using Kaplan-Meier and Cox regression analysis. So here is our chart showing 782 female patients with invasive ductal carcinoma. As you could see, stage 1 and stage 2 take over almost close to 90% of patients, and stage 3 and 4 are very minority of our patients. Then, of course, triple negative phenotype is coming along somewhere to 18% the most. And then if you do them and look at them at the stage, like non-triple negative versus triple negative, you would see that non-triple negative is overwhelmingly high, which was expected. If you look at the clinical pathologic characteristics of patients, so apparently the pointer is gone. There is no mouse which can be showing anything. So I'll try to screen and show you here that stage 1, sorry, okay, that stage 1 patients, non-triple negative, had grade 1 tumors, which was followed by the Nottingham score mostly. Then stage 2 usually had these grade 2 cancers, and of course followed with a Nottingham score of 7. And then stage 3 and stage 4, there was no difference in grade between the triple negative and non-triple negative. And of course, triple negative cancer patients were all grade 3 cancer patients. The size obviously follows the stage, but if you compare triple negative versus non-triple negative phenotypes, there was no difference in size except in the stage 4. But because stage 4 triple negative patients were only 3 of them, we cannot reliably do any statistical analysis in that case. Age, regarding the age, the triple negative patients were significantly younger than patients which were non-triple negative. The same situation I'm showing you here. It is very obvious if you do the Kaplan-Meier curve based only on TNM stage. You can see nice division between all stages, stage 1, 2, 3, and 4, and obviously stage 4 patients and stage 3 patients die significantly a higher rate. If you now include the triple negative phenotype and compare it with the non-triple negative phenotype, as you could see here in this part of the curve, all of these are stage 1 and stage 2 patients with triple negative phenotype and non-triple negative phenotype. And then in here you have stage 3, non-triple negative surviving better than triple negative, and obviously this part of the curve really splits up. So Bagheria et al. Found out that they were proposing in their study on 1,700 patients that every patient who is stage 1 and triple negative should be considered as stage 2 non-triple negative patient, saying that the triple negative phenotype just gives the worse survival advantage. However, in our study, we couldn't replicate that. So for stage 1 and stage 2, we have pretty much similar survival regardless of triple negative phenotype, but then that same thing is not true for stage 3 and stage 4. They split. In Cox regression analysis, we looked at the triple negative versus non-triple negative phenotype. We looked at TNM stage. We looked at the age and grade. And again, you can see here how the curve is split when you do only TNM stage and age. And then when you include the triple negative versus non-triple negative phenotype, it all kind of splits, but still stage 1 and 2 staying pretty much similar regardless of the triple negative phenotype. So in our summary of this study, we actually showed that TNM stage and age by themselves were predictive of overall survival, and with hazard ratios increasing, so that stage 4, for example, has a ratio of survival is 27.25 times more that these patients will die than stage 1, and age was just a little bit 1.05. And then adding the triple negative phenotype to TNM staging is predictive of overall survival only in higher TNM stages, but it was no significant effect of TNM stage 1 and 2. So then we come back to that initial study when we saw that in our Caucasian patients, we can't have the actually true, any significance of ER/PR/HER2 phenotype. And we did the same group of patients, divided them by St. Gallen grouping into luminal A, luminal B, HER2 negative-like, luminal B, HER2 positive-like, and HER2 positive non-luminal-like, triple negative, and then did the same overall survival curves. As you could see, there is any splitting between any of the phenotypes, showing again the same result, that overall survival does not depend on ER/PR/HER2 phenotype, as well as in Cox regression analysis, where we couldn't see that there was any advantage of ER/PR/HER2 phenotype. But in this analysis, TNM stage again mattered. So the St. Gallen ER/PR/HER2 grouping had no significant impact on survival regardless of TNM stage or age. So now this is just a glimpse of our ongoing study. He et al. From MD Anderson actually found out that if you actually try to incorporate ER status, grade, and TNM stage, you will improve prognostic accuracy of TNM stage. So we tried to do that the same. So you can do it on several ways. You get the final score when you score your ER status, your grade, and stage according to this table here. And then we had 1,108 patients. Total number, you could see that based on the final score, it nicely, survival goes down, showing you that the score of 4 has only 46%, 46.2% survival versus 85% final score 0. Then the Kaplan-Meier curve shows that survival nicely split. And then if you are wondering how our split was calculated and what was the ER grade and stage, you could see that there was not too many patients which were ER negative. Grade was like 1/3 of them, and stage was pretty much similar regarding the number of patients. And then here, if you look at the survival with final score, there is a nice split. There was no significant difference for ER status. Stage was significant, and grade was significant. But then if you do Cox regression, where you put all 3 of them and predict which one of them will still stay on to be significant, only stage predicted for survival, with score 1 being a little bit lower than score 2 in comparison to score 0. So in summary, our TNM stage and age are predictive of overall survival. Adding triple negative phenotype to TNM staging is predictive of overall survival only for higher TNM stages, but not significant effect on TNM stage 1 and 2. The St. Gallen grouping had no significant impact on survival regardless of TNM stage or age. ER alone and in combination with grade had no significant impact on survival, and stage is the only predictor of survival in this model. Our data support the traditional current TNM staging as a continued relevant predictive tool for breast cancer outcomes. Our results also suggest that biomarkers are relevant predictor of outcomes, but they primarily improve the accuracy of TNM staging in more advanced stages of breast cancer. And in early stage breast cancer, the ERPR-HER2 status had no significant impact on outcomes. We proposed the systematic analysis addressing issues such as types of classification systems used for determining the ERPR-HER2 subtypes, making sure that the systematic analysis of populations which are studied is also performed, such as other studies talking about Caucasians, minorities, mixed, etc. And then consistency in choosing the time periods in studies are conducted probably are also crucial. And this probably should be perhaps performed both nationally and internationally before biomarkers are fully incorporated into the TNM staging system. I would like to thank my collaborators, which most of them will present today. And happy day from Knoxville. This is our center. We were actually proud, I'm proud to say we are fourth year in the role between first 100 hospitals in US by US News. Thank you very much.
Thank